Thank you very much. And my name is Joan Martin, and I am the Vice President for Payer Contracting at Albany Medical Center. And I'd like to thank you for allowing me the opportunity to be the facilitator for this very distinguished panel. I think we're going to have a very good discussion, and we'll learn a lot. Making the shift through valuable partnerships. In my role at Albany Med, I work collaboratively and often with the payer community. And I am certainly, from my perspective, seeing the changes in the discussions that I'm having with the payers. It's different. I've spent 16 years in this role, and prior to that, I was on the payer side with a couple of different payers, Medicaid managed care as well as commercial. And I can tell you the discussions weren't always collaborative, and sometimes they were very heated. But I think going back to that question that Dr. Goodnick left us with, a wonderful presentation, what matters most, and I was thinking about, from my perspective, how can I bring that into my discussions more and more from my own perspective and the payer negotiation perspective? How can we collaborate to better serve our patients/members, because we're all in this business together. We're all trying to do the right thing. And thankfully, my time in payer contracting, excuse me, while I'm seeing this paradigm shift, I'm still standing. And I know that there's a lot of CBOs out there that have some anxiety about contracting and moving into that negotiation with payers. But I have to tell you, don't be afraid. Again, I'm here. I've been doing it for many, many years, and some of my best relationships are with my payer colleagues. So with that, how we're going to be doing this panel discussion is the panelists are going to introduce themselves. I will kick off after they introduce themselves. I'll kick off with some questions, and then from there, we'll allow the questions to be open to the group here. And if you could please look for the mic so that everybody has a mic and can be heard when they do answer or ask their questions, that would be most helpful. So with that, I'm going to go to the first panelist here.
Sorry.
Sorry.
Emily Engel. I'm the Deputy Director for the Bureau of Social Determinants of Health, which is within the Department of Health, Office of Health Insurance Programs. We like to just add a lot of layers to confuse everybody. So.
Amanda Bulris-Allen. I'm the Director of NAMI Champlain Valley, located in Plattsburgh, New York, and we're here talking specifically in conjunction with CVPH and the Max District Project.
Hi, I'm Brenda Stiles. I'm the Director of Clinical Quality and Practice Transformation for the Adirondacks ACO. And again, I'm going to be working with Amanda talking through what our process has been over the last 3 years.
Hi everybody, I'm Jim Moran, and I'm the CEO of Care Design New York, one of 7 care coordinate organizations in New York State, specialized health homes supporting individuals with intellectual and developmental disabilities. And I'm partnering up with Kerry Delaney today, and we're going to talk about the road to managed care for us and value-based payments.
Good morning, everyone. I'm Kerry Delaney. For about the last 2.5 months, I've been the CEO of Partners Health Plan. Immediately prior to that, I worked as the acting commissioner at the New York State Office for People with Developmental Disabilities.
Thank you very much. We're going to start with Jim and Kerry. Can you describe your partnership and the pieces that are perhaps related to value-based transformation?
Sure. I think one of the things we thought, not to go off script too much, but we think it would be good, because I don't know the audience, how well the audience knows the field of intellectual and developmental disabilities. So we kind of wanted to just give a thumbnail, if that's okay, around the background on the system. Kerry can talk about the introduction of managed care. Because right now, quite honestly, this field of intellectual developmental disability services is we're at a point where it's really a sea change for the field. And quite honestly, it ranks up there with the movement out of institutions on the part of the state, in the late 70s into the 80s and 90s. and then the introduction of a home and community-based services waiver in the early 90s. So the movement to managed care is sort of the next trajectory of our field. So by way of background, just for those who are not familiar with OPWDD, currently the population supported is about 130,000 people, of which about 45% are dual eligibles. So it's a very high percentage of people with Medicare and Medicaid. The system, the IDD provider network system, is between 600 and 700 service providers. Most of the services are provided by the not-for-profit sector, about 85%, 15% by the state, which has actually dropped over time. And total Medicaid spending, which I think is something that most people are not familiar with here, is about $8 billion for Medicaid for the population, of which about $7 out of $8 is for the IDD services. So only about, $1 billion goes towards healthcare, long-term care, medical, physician costs, pharmacy, et cetera. So that's a little bit of background on OPWDD. And then Kerry quickly can talk about the shift to managed care and where the system is, just as a little backdrop before we get to value-based.
Sure. So the state, for the last 10 to 12 years, has been talking about managed care for people with developmental disabilities, and specifically the home and community-based services that they receive. It's been sort of a long pathway because much time was spent looking at what other states have done and the experience in our state with other populations in long-term care types of situations. And there were a lot of lessons learned. But about 2 years ago now, the state issued a roadmap for the transition to managed care for the IDD population. We have about 25,000 people who are now in mainstream Medicaid managed care plans, but they are not receiving their DD services, their home and community-based services, through those plans. So the first step in preparing for this transition was the establishment of the care coordination organization. So we took our over 400 Medicaid service providers and brought them together behind 7 regional CCOs, of which Jim's organization is one. So that was sort of phase 1. This year, we are moving into what we call the early adopter phase. And what's happening there is provider-led plans, because in the state there was a desire to see DD provider-led plans be at the forefront in managed care. So these provider-led plans are coming forward and going to the Department of Health and requesting the authority to provide managed care, not yet for the home and community-based services, so not yet for the DD services, but for all the other services that someone is getting through Medicaid. The plan would then be that over the course of the next year or so, the DD benefit, the HCBS waiver services, would then be added to the benefit package for those provider-led plans. Mandatory enrollment is expected to begin within about a year or two after voluntary enrollment starts for those plans. And as of right now, because the CCOs have been seen as a step on the path to managed care, the CCOs are beginning their work in alignment with the provider-led plans that will be established.
Hence, Care Design and Partners Health Plan. Partners Health Plan is actually one of the organizations that helped form Care Design. And so they're one of 7 member organizations that formed the CCO with us. So we've actually had a close relationship. Right now, PHP operates in the 9 downstate counties through the FIDA demonstration currently, but they're expanding, as Kerry spoke to, along that pathway. So eventually they will be up here in the capital region, and actually all of the counties in which Care Design operates. So to talk a little bit about our partnership and how we get to value, I think that we're going to look to formalize our relationship with Partners Health Plan. We're working with our boards on what that might look like. going forward. That would still give Care Design the opportunity to work with other organizations, because a lot of our members, we support about 26,000 individuals from Care Design. We're from Long Island, the tip of Long Island to the Canadian border. So we're not out west, we're not in the western part of the state, so we kind of, as far west as we go is Amsterdam, the Montgomery County area, but we head all the way up the north way to the Canadian border in terms of where we are. So the thought is that Partners Health Plan will become operational in those counties. We're in about 30 counties, so the plan is to kind of work on a plan of how to get there. So I think we have a shared vision as to what it's going to take to support people with intellectual and developmental disabilities. We all have background in that field. Part of the learning curve for a lot of us is going to be around the healthcare side of things, and that's sort of a, that's not necessarily my personal strength is not, but we have a good leadership team that is comprised of people that not only know the DD field, but also know the medical side of things. So the opportunity here is us to work together and to really seek how are we going to do things in a better way. Right now, our field has been so hung up on fee-for-service as sort of the payment mechanism, a lot of questions and a lot of concerns around fee-for-service, but in the end, providers really like fee-for-service. They don't like to admit that, but we really need to get to a better place in terms of really more focused on outcomes and measurable outcomes for people with intellectual and developmental disabilities. And quite honestly, that has been a challenge in our field. Whether you look at across the nation, coming up with true metrics for the population beyond the ones that are strictly health measures, which are important measures. But coming up is how do you measure the quality of services being provided. As I said, $7 out of $8 spent on services that connect to the person, daily life, whether it's housing, residential supports, whether it's what do they do during the day, hopefully work, the relationships they build in their community, and having good health. So it's like, how do you come up with, and trying to get agreement on that in all honesty, has been a challenge. Not just in New York, but across the country. So we have a lot of work to do in figuring out what are the best metrics and measures as we move towards value. So I don't know, Kerry, you want to add a couple of things to that?
I don't think so. I think that we're set on background.
Okay. Can you help us understand some of the transitional challenges and barriers you've been experiencing with this collaboration? And I know this is a very unique population, and it has, sometimes it can be extremely complex, never mind complex overall. So I'm just curious, and perhaps others are curious too, as to how you started to build and how you started to transition both your organizational goals.
So the first thing I would say is that in the DD field in New York State, stakeholder engagement is paramount. And our system of services in New York State became a separate system and was run by a separate agency because of the advocacy of parents and family members of people with developmental disabilities, going back to the days of Willowbrook, which some of you are probably familiar with, and the other large institutions. So we've always had a very heavily stakeholder-influenced public policy. And one of the things that we had to spend a lot of time doing in preparing for this transition was stakeholder engagement and stakeholder relations. And that's true even now with both of our organizations. And when Jim alluded to having challenges in setting these measures, the thing we hear from our stakeholders is that people are concerned because in our system, we look at things like the quality of someone's life. Are they achieving goals that they have set for themselves? What does that mean? How realistic are those goals? What services and supports are needed to help achieve those goals? And what is progress towards meeting those goals? So we've struggled somewhat with how to develop outcomes around these issues, but that aren't process measures. So I think in terms of the challenges that we've seen overall, Fear in the stakeholder community from the Partners Health Plan side continues. And I think in terms of our relationship, when the CCOs were started, it replaced Medicaid service coordination agencies that in some cases were very close to the families that they were serving. People knew their Medicaid service coordinator on a first name basis. People had relationships with them. So there was a lot of fear and a lot of resistance because people were scared that by losing their Medicaid service coordinator, and many people actually were able to keep that person, they would lose their connection to the individualized focus that we have had. And I know Care Design and PHP have both tried to maintain that focus in our operations, and will continue to do so because it really is something that I think is unique about our population and has to be carefully considered as we move forward into managed care, and in fact is one of the reasons why provider-led plans were developed.
In terms of trying to mitigate some of these challenges to really get to true value-based arrangements, I think one of the things, and paying attention to the healthcare world and what's going on and listening to this morning's keynote, it helps me to understand where we are versus where the health community is. And I think one of the things that I think we've had, and Kerry kind of alluded to this fact, that as we support people and have for many, many years, we've been dealing with sort of this, what now are called social determinants for a long time for this population. So whether that be focused on housing for people, whether, as I said, so it's housing, it's on meaningful activities during the day, which, again, pushing more and more around employment. The highest unemployment rates in this country are for people with with intellectual and developmental disabilities. I think it's somewhere around 50 to 60% unemployment rates. So working on that aspect of things, healthcare, very important. Preventive care, very, very important kinds of things that we need to do. And the other one is building relationships. The individuals that we support are seeking relationships, not with staff. They're seeking relationships in their communities and being a part of their communities. So those are things that we've been working on, and we're still working on. This is a work in progress. You never kind of get there. You always can do better. But I think that from our system's perspective, we do have, I think, the things that can get us there. As Kerry mentioned, the struggle has been getting people past the concerns around just a simple movement to managed care, quite honestly. So it's hard to get off the conversation about why are we going to managed care? Why are we doing this again? Why do we have to do this, right? And that's not only the families, and it's really all stakeholders, including service providers that provide OPWDD services. So it's really getting people past that stage and getting them to the point where how do we utilize this to not only provide quality services to people, but how do we make the system more efficient and effective? And I think this is where we can work on regulatory, as we get into managed care, you can break down some of these barriers around regulatory requirements, and how we can streamline some of this. How do we really focus on program quality for people? And how do we eliminate, quite honestly, I don't see fee-for-service as sort of where we want to end up here. It really is about setting up value-based arrangements because you want to be focused on quality and outcomes for people, not on still thinking about I'm billing for an activity, and in our field could be as little as 15 minutes. You're billing every 15 minutes for a service. So that's not what we want people focused on, right? And the infrastructure that they had, the systems that are put in place to deal with that. It's really about moving the needle really where it should always have been, which is focused more on outcomes for people. So I think we will break down these barriers together, and I think we'll use ourselves as a model for this. Care Design, working with, Kerry and I have the privilege here of having worked at OPWDD for a number of years together. So I think we make a good team. from that perspective, and we really know each other very well. And I think that benefits both of our organizations in terms of getting us across this line. But I think we want to set the example for our field, and I think we can do that. We want to be leaders on this, so we're very excited really to be together here and to figure out how can we make this better, and how do we alleviate those fears that our system currently has. And that's a work in progress.
I think we will all agree that everything's a work in progress these days, but everything that you're stating is applicable to any population, and we really do appreciate those comments and the example, because I think it shows how payer providers are really rolling up their sleeves and trying to figure out how to move the needle, like you said. So with that, we have another wonderful example. Brenda and Amanda will describe what their collaboration looks like, and we'll just continue on with our questions.
Okay. So about 3 years ago, we were asked to participate, and probably many of you, in the MAC Series program that was offered through DSRIP. And we had the pleasure back in 2016, I can't believe it's been that long ago, to really focus on our people utilizing the emergency room, and really how are we going to create a different experience for them. We knew that people didn't want to be using the ER, but how are we going to change that? And there was many pieces that really we needed to look at. So with that, we actually brought all of our community partners together to really be able to look at what our processes were and what was it that we were going to do to really create a different experience for the people utilizing the emergency room numerous times. And part of that really was going to be a culture shift for not only the ER staff, but also our community partners, and how we were going to work together. Because I think the silos were in the early phases, we were still all trying to figure out what is our role, how do we work together, how do we pull this off, and really create that different experience for our patients.
Yeah, so what we noticed was 2/3 of our 2016 cohort had behavioral health and substance use disorder. Some of the common characteristics included medically complex substance use, behavioral health, social isolation, unable to navigate community resources, transportation, like many other communities, is a huge issue, medication, no primary care provider, or the perception that they have no primary care provider, because that was also an issue. Food insecurities, lack of resources. Many were utilizing the ER for non-emergent issues, dental issues, and individuals not feeling like they had much control over their life in relation to health in general.
So with the community partners sitting down and really taking a look at how are we going to move this needle. And really, when we talk about our original cohort, we actually had 91 patients that had 10 or more ER visits. That's how we had to start our focus. So it was a little bit daunting on how are we going to know who these people were when they were coming to the ER. We knew that the staff in the emergency room were already, at capacity trying to help the people who were coming in. But what were we going to do to change the experience, and also what kind of supports? So through a lot of work with our IT department, we created real-time alerts for those people when they came into the emergency room, as well as pulling our community partners together on a bi-weekly basis, where we came together to discuss the patients that we had identified, and actually making a community partner responsible for the engagement of that patient, and then creating that plan of care. To bring that plan of care together so that when that person did show up to the emergency room, that we knew who their community relationships, or where those relationships were. A lot of times these people presented, they had no idea that they had a health home care manager, that they had a care manager at their primary care. Many of you already know that. So how did we get around that? So being able to create the care plan when they walked in, we could actually contact who the partner was that was going to engage the patient when they showed up to the ER, and really start that work. And we had really great success. I'm trying to tell you something that took place over 6 months in 3 minutes or less. So really, it was the community partners coming together, and everybody bought into this. We knew that we had to bring everybody together. And really, NAMI really stepped up to the plate because they had a lot more flexibility than our other community partners. And the community partners were the Department of Social Services, Behavioral Health, our Clinton County Mental Health Association. All of these people were there together, but certainly working within the realm of what they were able to do within their organization. NAMI was able to come in and really flex what they did with some of these patients and really be able to engage them and help them really start navigating the system, and really found out what is it that was going to move the needle for these patients and helping them to engage in their care. Through that, we actually saw with our original cohort a 75% decrease in the utilization of that original cohort. So we knew the value of our group coming together and working together. I think the biggest problem was really the continuance of the program, because the amount of work and effort that this original group put in, that there was no way that we could continue to sustain this without dedicated members to be in the emergency room. I think one of the things that we saw was a lot of our emergency room personnel that were there were always picking up the phone and calling NAMI or calling one of the other community partners to say, you've got somebody here, what can you do to help us? So we really knew that to continue that work, that we really needed to partner and look at a different way and have these resources available in the emergency room. And through an innovations grant through DSRIP, we were able to secure 2 positions for the ER. One was a community resource advocate, along with a peer support that were in the ER full time to really work with these people once they were identified.
Amanda, you and I had a discussion before when we were sitting down and just preparing for our session, and you had talked about feeling that the collaborations that are happening now in the community are just much more rewarding. Can you talk to that a little bit?
Sure. I mean, we've all operated in our silos, and to some certain extent, we still do operate in our silos. However, I think that we are breaking them down little by little. And so I think this type of work can be really challenging, but at the same point in time, having the opportunity through DSRIP and the collaborations in the community to really see real success for these patients or clients or whatever word you use. And really when we talk about what matters, really looking at what is success for that person, because I may define success different, and that's okay. And so with, I had the pleasure of myself working directly with some of these clients and really seeing, like, through the community collaboration, and Brenda and I will talk later about one of the original participants in the program, and I actually have a speech that he wrote up. Just success and that relationship and building, and now the patients are really directing, I think, what healthcare looks like. And healthcare isn't just physical health, but the whole, mental health and spiritual health and so forth. So it has been very rewarding from a community-based organization standpoint.
Thank you. So as we move on our presentations, Emily is going to speak to us about what's happening on the value-based payment front with respect to the state, and if there's any particular initiative or best practice that you'd like to point out, that would be invaluable to us.
Sure. So I guess I'll start by asking, does everyone know the contracting requirements for social determinants of health and community-based organization? Just like a show of hands. Okay, you're scaring me. So the state requirements are that plans, as they're moving into level 2 and 3 arrangements, going back to that earlier graph, the DSRIP, where the little arrow is pointing down. So as plans and VBP contractors are moving into level 2 and 3 arrangements, they have to implement at least one social determinant of health intervention per arrangement and contract with a community-based organization. And this requirement started, it was effective January 2018, right around the time our bureau was established to work on the compliance of this requirement. And thus far, 61 contracts have been approved, which in the beginning it was a trickle, because We had plans thinking about, well, how am I going to make this work, and how does it fit? How do I really integrate, clinical and social services? And we had community-based organizations wondering, like, how does this fit into my organization? I'm used to the grants world. I'm not sure if VBP is right for my organization. And then once everyone could decide, whether to call it a participant, a member, or, a patient, and everyone got on the same page, we started seeing the contracts trickle in. And so for this requirement, we really, the state, and was implemented by a group of stakeholders. So everybody was in the room, including community-based organizations and plans and hospitals. Everyone had a seat at the table in kind of shaping the roadmap and what the requirements were. But we saw a different, implementation for each region of the state. In most of our contracts, we see managed care organizations actually contracting directly with a community-based organization. And I think in the beginning, plans may have already had pre-established relationships with community-based organizations. So community-based organizations are able to say, hey, we're already serving your members. We can really help you, drive down your Medicaid costs. In other situations, plans took a really hard look at their data, and they decided what to target. As far as best practices, though, I would say screening for all social determinants of health is super important. We know that it's not just someone who needs nutrition, they need transportation. And they kind of all work together. So by screening for social determinants of health, you're able to look at interventions with more than one community-based organization. And we've been really trying to stress that this isn't like a grant where the community-based organization, only one community-based organization in the region can win. It's everyone can work together. And we've been really trying to push that collaboration, and that there's not just one piece of the pie, there's a whole big pie. And with value-based payment, if everyone can collaborate and work together, we can really make an impact on the person's health. So I guess that's the long way of saying best practices is A, to work together, and B, to address more than one social determinant of health issue that's in your area.
So just what I am hearing, and I'm hearing it from everybody, is that healthcare management and healthcare is local. And there's going to be a different initiative that meets the community need wherever you go. So there's not going to be one program that's going to work in every community. And I'm seeing that. I'm seeing that in the discussions here at these trainings, as well as the trainings that the DSRIP programs have been holding with respect to the community-based organizations. There's just a number of different initiatives, and there's just pockets of change, pockets of moving that needle. So I do very much appreciate your comments, and I think flexibility is also one of those items that are key. I'm hearing that from the NAMI experience and others, that you need to do things differently and think differently. So with that, I want to open up to the audience. Any questions? And again, we'd like to make sure that everybody has a mic so that everybody can hear the questions. The mic is coming.
This question is for Emily. Emily, how is the Department of Health supporting, I mean, you talked about compliance, but is there any opportunities where you can actually provide supplies for, or the actual social determinants of health? We're using the health, not health grades, I'm trying to think of the name of it. One of the nationally known social determinants of health screenings. But what can, I guess in the shortened way to say it, can the Department of Health, this department, this bureau, do to help people that are trying to do the screenings and trying to direct their patients to the correct agencies?
No, that's a great question, and I will say that we are focused on the value-based payment implementation. We are looking at ways to, we've been doing a lot of trainings for community-based organizations. We have a bunch of webinars on our website and we're trying to engage, the performing provider systems, platforms like this to really talk about value-based payment. As far as screening, we've been thinking a lot internally about how to scale social determinants of health, right? It's great if a plan has one contract with a community-based organization, but how do you really scale that, and how do you increase the screening for social determinants of health? And we did a survey probably about a few months ago where we said, like, okay, how many people are actually screening for social determinants of health? And we're surprised it was under 50% for the whole state. And we're like, well, how do we increase that? So we've been looking at ways to, increase the screening for social determinants of health. How do we incentivize that? There's three main tools used. It's the ACO tool, the Prepare, and the health leads. And so if we know that all the data is coming from there, how do we really harness that data and allow it to drive policy and initiative and share best practices with everyone? So we are talking about that internally, about different initiatives that our Bureau can do and the Department of Health can do. But right now we don't have anything in place to address your concern. But we're definitely thinking about it.
Are there any other questions? Well, then I can continue to ask my questions. Oh, okay.
Just, it sounds like a lot of interesting things are going on, but I had a couple of questions. One was with the Department of Health with the 61, I guess it's 61 contracts that you have out there now. Is that information available in terms of the scope of those efforts to share with other community-based organizations? And then also, how are we doing in terms of, a lot of data is being collected and analyzed, and most of it is focused on the healthcare needs of target populations, but how are we doing in terms of then sharing that with the community-based organizations so they can learn more about what's going on in their neighborhoods and their communities and use that to improve their service provision as well?
Yeah, we are actually working on making a public document for all the state contracts. So that's a great question because we think that'll be really helpful. I will say upstate, there's only been a couple actually approved for this region. So there's definitely opportunity. The well's definitely not dry. There's a lot of arrangements still moving into level 2 and 3. And as I said, only a couple in this region. So there's definitely an opportunity for collaboration and VBP contracting. As far as data collection and data sharing, that's been a huge topic. We think it's so important that not only the flow of data is going from the managed care organization saying, hey, here's our high utilizers, can you help me target these people in an intervention, but also then the community-based organizations sharing data back to the plan or VBP contractor saying, yes, this is who we're reaching out to, here's the data, this is the intervention they received, but then it has to come back again, right? So community-based organizations have to know, hey, this is effective, we're meeting milestones or marks, this is the effect that our intervention has on Medicaid usage. So we are actually working on roadmap language to clarify that in the roadmap because some contracts, again, are really robust with that data sharing back and forth, and then some contracts seem to be a little bit more downstream. And so, but we recognize the importance that community-based organizations have to be able to gauge how they're doing and also build their organization, build their VBP, and you can only do that if you have that Medicaid data, and so we're working with plans on how to share that properly.
Any other questions?
Can't we just copy what some of the other states are doing, like Oregon and Washington and California? I mean, they seem to have rolled it out, made it work, gotten the buy-in from the providers. I think that's the hardest. I struggle with these providers. They just push back, and even within my own organization, to get somebody to think differently. Ugh. So it's like it has been successful in those areas. We know it takes about 5 years to get to our coast from the West Coast, but could we emulate some of that?
Yeah, I think we actually do have constant contact with the different states. You have to understand they're all in kind of different positions. Like, for example, some of them are just implementing managed care. We've had managed care for years now, so we can't really replicate the same system exactly. But I think it's also important to realize that when we rolled this out, there's a lot of flexibility, because downstate, you can't treat downstate like upstate, you can't treat upstate like downstate. It's an individual, there's no cookie cutter answer. So if you look at the roadmap requirements, we do require the social determinants of health. A couple of the other states have followed that as well. But we as a state don't want to say this has to be your social determinant of health intervention. Like, for example, North Carolina, they're just moving into managed care, and they're really focused on, transportation, food security, and housing, which are definitely some of the top domains. But we want things to be able to be individualized to the area. We didn't want to say, okay, this is how it has to be for every single geographic space in New York State. And we are trying to encourage, one thing Washington's doing that's really interesting is they're pooling funds. So plans or I think it was actually 3 hospitals pooled funds to create a housing project. That's neat. And so we're thinking about ways to kind of share those best practices, and even if it's a roadmap update, allowing and not that we didn't allow it before, but saying, hey, you can pool your funds, you can invest in projects together, which is a different state of mind, right? But I think it is important to learn from other states, but at the same time we are an individual state, so it has been a little bit slow, but we are meeting the level 2 and 3 arrangements, the percentage. And I think I see, the trend of people starting to collaborate and work together and kind of break down the silos that everyone was talking about.
There's a question back in the front as well.
Amanda, how are the services that you provide at the hospital reimbursed or funded?
So currently, they're being funded through a contract with CVPH through DSRIP money. We are looking at sustainability, and we believe that there will be a sustainability plan. I do think moving forward that this is going to be a project that could be replicated in other communities. So hopefully it will be viewed or seen as an evidence-based program that works for folks. So.
My question is for Emily. Hi, Emily. I'm Lori with Central Nursing, and I'm located in Troy. It's been my experience in working with some of the managed care organizations and trying to develop a value-based contract that they are asking for data on my behalf. We do submit a Medicaid list to our PPS, but they also share the same data. Is there any discussion at the state level with the MCOs to kind of move beyond that and look at their own data to see the value in what we are sharing with the Medicaid list?
Yeah, we are looking at doing like a roadmap update possibly to kind of, we've been talking about it in public, and we've been talking about it to the plans, because what you're saying is really important. So we've been looking at how we can, put that more in stone and really share that is what should be going on.
Yeah, because it's been my experience that it right now has been a barrier to being able to move a little bit quicker towards value-based payment and contracting. And I did attend the last population health seminar at the Empire Plaza just recently, and the data submitted from the state, it looks like we still have a lot of work to do with the MCOs to get them on board.
Yeah, and I mean, in the plan's defense, that we have a ton of HIPAA requirements, the state, right? And so it can be, it's always share less, not more. But in the case of VBP, we feel that if there's the data sharing agreements in place, and you can share information back that isn't PHI identified, that's really a best practice. But also sharing those targeted lists are important. So if you have a data sharing agreement and you're saying, hey, this is who you should target, that's super important. And so, like I said, we're really going to try to stress that, and maybe either a roadmap update or different guidelines that are coming out.
Thank you.
So there's the targeted lists, and there's the population identification and the case management and all of that that happens. But from my perspective, and working with the MCOs in my discussions regarding VBP, it has been challenging to figure out how the data exchange is going to work. And Kerry, I don't mean to put you on the spot, but what is Partners doing to create that continuous data feed so that if I was in a VBP arrangement, I know what's going on with not just, because I am so impressed that, you know, the conversations are so centered on the patient and triple aim and all, and the value and the quality, but we can't forget the financial component as well. I can't, not in my world, but, you know, can you speak to that?
Sure. Well, I would say a couple of things. First, just at the provider level, separate from PHP, the state provided money several years ago through certain grants for provider readiness for managed care, which included the development of electronic records and mechanisms for data exchange. Partners Health Plan has been in operation since 2016, but in development for a couple of years before that. And Partners had actually worked with a company on developing what we call our life plan and other assessment tools. The life plan ultimately being the document that helps to authorize services. As the CCOs were being stood up, they worked off a common platform, and we expect that other provider-led managed care plans in the state will do the same, because there has been development already of an electronic system that's designed to help with information exchange, standardization of data, and maximizing on work that's already been done. But we do have quite a ways to go.
I mean, Joe, I just want to say
Please.
from the health home perspective, I think we're considered a level 3 from a security perspective. I think we have the highest, right? I'm not sure if 3 is the highest, but it's intense, right? The security requirements, which I think is a little different than the current behavioral health home system when that came into play. I think the timing was such that they were rolling out new requirements. What I found like very intriguing is that health homes do not have access to data.
That's right.
And I'm like, we're a care management organization, and we don't have data on individuals. The people that we support, we can't get that data. And it's like, how could this possibly be, right? If, you know, again, it's only one part of information, but it's data, and it's something we all need. So as I think about whether it be, you know, going to providers and how to get providers into a network, I don't have the history to know without staff somehow putting that into the system. I don't know what the relationships have been. So when a provider, let's say a hospital comes to me and say, well, why would I want to join? Why would I want to be part of Care Design's network, for example? I don't have data, you know, I have generalized information, but I don't have real data on our people that we're responsible for. And I just find that to be absolutely crazy and ridiculous in this world today when we're level 3 security, which basically we have access to people's Medicaid IDs. And we need a level 3 security for that, apparently. So that to me, it just shows how we've got to move the bar here with the health department, and I know that there's discussions around this, but the decisions, policy decisions around who should see what, have access to what, should not be made by the Bureau of Policy, of Security, and, right, they're the ones that tell the program people in DOH what needs to happen to secure the information that can be shared with providers, right? Or in this case, a CCO or health home. So that to me has been one of the amazing things that I've learned, and not only learned this recently, that we were never gonna get access to the Medicaid data warehouse. It's just ridiculous. But one of the other things I think from a care design perspective is that when we looked at what we were gonna do here, when we first were thinking about the formation of the organization, it wasn't building it for the July 1st change, which took place that Kerry referenced with MSC, you know, Medicaid Service Coordination, shifting to care management and health homes. It was really about how are we going to navigate in the managed care world as an organization. So for us, it's building those relationships. So we brought in a team of people, and we're working with, as an example, and trying to build out our infrastructure from a data analytics perspective. We've got a great team of people, but we still don't have the data. So how we get access to data? So one of the things we've talked about at Care Design is working with Staten Island PPS, who has a very, very robust data warehouse system that we've been meeting with them to talk about how can we partner with them. Because now we have to do workarounds, which is probably what you all do. You do workarounds to get what you need to do the best you can. And it's like, that shouldn't be, but that's what we're all, probably faced with. So for us, it's about how do we build out so we get the data that Joan's referring to, because that's all part central to how do we move this. You need data in order to make informed decisions and how to move things. So to me, this is a major challenge, and it sounds like you've been struggling with this
I'm
for a
behind
while.
you, Jim. We'll carry the
So-
flag.
Yes, no,
absolutely.
I get very passionate about these things.
I do too.
As you can tell.
I held back a little. Absolutely agree. Are there any other questions?
Hi, Emily, this question is for you. I'm Perry Janjulis from the Albany Demian Center, and I'm going to speak from the perspective of a Tier 1 organization that does not bill Medicaid currently, and the majority of our funding is state grants. So our state grants, like many others, are very prescriptive as to what we can and cannot do, although we are working on essentially a lot of the social determinants of health. Has there been conversation at the state of how or if we are going to be able to adapt our grant-funded programs to be able to interact with the value-based payment world?
That's a great question. So a key, though, is that your value-based payment contract should be giving you not only upfront funds to implement the program for the Medicaid membership that's covered under the VBP arrangement, but also all of the contracts thus far has been for payment services rendered. So typically it's worked out between the plan and the community-based organization that you're getting quarterly, funding based on the services that you're performing, right? So it's important to keep in mind that the plan should be paying for those services for the membership that you're serving. As far as state grant funding, sometimes that could be covering other state priorities. So can it be, braided and work alongside? Yes. Can you pay grant funding for a Medicaid member that's also under a VBP arrangement? That would be supplanting, and we would want to see that money coming from the VBP arrangement, not the state grant funds. Does that make sense?
Sure. I think from the financial perspective, that makes sense that we couldn't double, pay on that. I'm just...
But if it's different services, absolutely.
Okay.
So if, for example, the VBP arrangement is covering, food security in your DOH or OTDA or whoever,
Yep.
grant is covering, transportation or some other type of services, then those could be used possibly together. And maybe it's just a conversation with the state entity. And, if you want to grab my card after, I could help you out if you're having any barriers.
Oh, no, I guess my curiosity was with the state grants, this is a big leap for us to, consider, joining this. I just want to make sure that the state grants would be able or flexible enough to be able to allow us to enter this world.
Yeah, absolutely.
So,
Yep.
okay.
And I think it's an opportunity for community-based organizations because, you have your grant funding, and sometimes grant funding shrinks, or sometimes it has constraints. And with VBP funding, it's another source of funding. So it's not replacing grant funding, but it's another stream to grow your organization and serve more people.
Thank you. Well, we are out of time. I'm getting the signal. So, I just want to wrap up briefly and thank everybody on this panel. I think this has been a wealth of information and hugely important to share what everybody is doing. Just a couple of key themes. I don't think that there's going to be any moving the needle or shift without valued partnerships like these. I mean, that's my perspective, and I know several others. So we need to continue our good work, and it's been extremely good work. Collaborations, relationships, engagement, rolling up your sleeves, getting to work, cultural shift is a big piece of this. You know, getting everybody to think innovatively and differently. Breaking down barriers, hugely important. We got to define them. We got to figure out what they are. We need data. We need infrastructure. We need resources. So it sounds like everybody is moving towards the same goals here and identifying many of these common themes. And I think we need to continue these discussions. And I'm very passionate about this, as my colleagues in the audience know. And I thank you very much for your words and your insights. So thank you. Let's have a great round of applause for our panel.